standing to determine whether and how autonomous individuals put non-health related commodities to use. I think that's an important point to be made. An independent choice model for the doctor-patient relationship would improve access to these services while reducing patients' risk of surprise and embarrassment. The model would bring simplicity, efficiency, choice, and control. And if some physicians do not like providing these services, they can quit that area of medicine. That is one option. We have a choice, we the profession, we the broader society, and the choice will be made through all of the instruments of politics, as these sorts of choices always are. What I would like to emphasize to you is that it is a consequential choice. The profession can continue to ask its members to commit themselves to an objective goal, namely health, the well-working of the organism as a whole. That is not subject to wholesale revision. If this commitment is maintained, the profession must allow conscientious refusals where there is reasoned dispute about whether an intervention is consistent with that goal. Or the profession may constrain the scope of conscientious refusals and move more toward a provider-consumer model in which physicians' moral and clinical judgment is really beside the point. It's irrelevant to their task of providing what patients lawfully seek. But we can't have it both ways. So here I'd like to describe three logical, if unintended, consequences of taking the latter route, and propose that if we choose to restrict conscientious refusals, we, the United States healthcare system, we, the society, if we choose to restrict conscientious refusals, we may lose more than we gain. First, any policy that constrains the scope of conscientious refusals thereby erodes the possibility of conscientious practice. I think it's somewhat hard for people who don't object to the things that are controversial to see why this is the case, but let me see if I can make the point. It seems obvious that patients want their physicians to be conscientious insofar as possible. Few would respect or desire the care of physicians who are in the habit of doing things they know to be unethical. Fortunately, individuals from virtually all moral traditions and communities can conscientiously commit themselves to caring for the sick. That's one essential reason why the profession of medicine has been able to maintain both prestige and unity in a society made up of so many different moral communities. Yet if physicians must be willing also to participate in contraception and sterilization, those who believe what the Roman Catholic Church has taught for centuries about the body and human sexuality, or those who believe that physicians should aim at health and nothing else, will no longer be able to practice conscientiously. If physicians are required to refer patients to those who provide abortions when requested, those who believe that such referral makes them complicit in a gravely immoral action have to quit. And so the process goes. Every time the scope of conscientious refusal is narrowed, the pool of people who can be conscientious physicians is reduced. Eventually, the only ones left will be those who are willing to make all legal medical technology available to be used by patients according to the patient's judgment, period. That's the first consequence. We make it more difficult for physicians to practice conscientiously. The second consequence is that by requiring physicians to do what patients request, we set physicians and patients at odds with one another. Quill and Brody argue that in the independent choice model, quote, the physician as a person with values and experience has become an impediment to, rather than a resource for, decision making, end quote. I would add that the patient also becomes a moral threat to the physician. Now we know, in the past years we found out that physicians are mortal threats to their patients in many cases, with all the mistakes we make. But in this case, patients would become a moral threat to their physician, particularly if restrictions on conscientious refusals take on the force of professional or legislative policy. Physicians will then need to wonder when their patients might, with the backing of legal sanction, ask them to act against their own understanding and to do that which they believe is unethical. So by making physicians obey patients, we make patients a threat to their physicians. The third consequence of reducing the scope of conscientious refusals is that patients will lose the basis for trusting that their physicians are committed to their good. Benjamin Franklin once said, if we restrict liberty to attain security, we will lose them both. You may have heard that quote many times during the Bush presidency. People were concerned about the administration's pursuit of security causing a loss of both security and liberty. But I think a similar dynamic is at work with respect to the practice of medicine. If we restrict professional autonomy and physician discretion to preserve patients' interests, we will lose both professional autonomy and the basis of hoping that physicians will seek their patients' interests. So why is that the case? Well, under the old model of paternalism, patients could trust that physicians had committed themselves to the patient's best interests, albeit in a limited way, only insofar as those interests included restoring and preserving health. The patients' rights movement and the rise of the doctrine of informed consent qualified and delimited physicians' commitment to pursue health, I think in an appropriate way. Because health is a relative rather than an absolute good, that's an idea that's been part of the Catholic tradition for forever, patients are authorized to relativize that good to other concerns, such as not being overburdened by medical technology. Yet within these limits, that is, with a commitment to only acting on a patient with his or her at least implied consent, physicians remain committed to the patient's best interest, at least insofar as that interest includes health. But models that support constraining conscientious refusals differ, it seems to me, in a fundamental way. In them, patients not only relativize the good of health to other concerns. They not only say, Doc, I know you think I should have the chemotherapy because it's the only hope really of restoring my health, but I'm going to relativize that to another concern, which is I don't want to be burdened by all the effects of that treatment given my advanced age or other conditions. Not only can they do that, but they can also define which goods physicians will seek. You must help me obtain the following good, whether or not you think it's good. Patients gain technicians committed to cooperation, and they lose healers committed to beneficence. They gain control over physicians, but they thereby necessarily divest physicians of responsibility. As a result, Quill and Brody note, patients will often navigate treacherous medical terrain without adequate medical guidance. Physicians can wash their hands of patients' decisions so long as the physician gives accurate information and provides technically proficient healthcare services. I'll tell you a place you see this, to me, I see it dramatically, is in the medical intensive care unit and on the wards, where we've seen the culture of medicine shift in a profound way to when people have to make decisions. We're so concerned about autonomy that we're in effect sort of drawing a circle around patients and their families and saying, this is your decision. Now, when it's your decision, who's responsible for that decision? People in the circle, not the doctors. And I can't tell you how many times I've heard people in implicit and explicit ways say basically, this is your decision, which is another way of saying, I'm not to be held responsible for what happens here. All right? I've discharged my obligations. I gave you the information. Now you live with the consequences of your decision. It's a very different way to think about the practice of medicine than I am here to care for you and help you get through this and use all that I've learned to offer it to you with all of its limitations in hopes that we can make wise choices. And I'm responsible for doing that with you and for shouldering some of the responsibility of these decisions. So with that rabbit trail, one cannot merely constrain the scope of conscientious refusals and leave all else the same. Policies that devalue conscientious practice and or make conscientious practice more difficult thereby reduce that which makes the practice of medicine its own reward. The confidence, the conviction that what one is doing is very good. In other words, if physicians surrender their commitment to do only that which they believe is good for their patient's health, they will also surrender the nobility, the joy, and the other intrinsic rewards of medical practice. Their morale will decline, and indeed has already declined, because the practice of medicine has been quite literally demoralized. There's a better way that has been iterated again and again by the clinicians and ethicists I've already mentioned. Again, interestingly, ethicists who, some of the folks who've written about this are people that support physician-assisted suicide. So they've people with whom I would have deep disagreements about a lot of topics, but they've said, but at least we ought to, at least that when a doctor goes to practice, he or she ought to go without a pretense to neutrality, ought to go using all their best understanding to try to care for people and make good decisions. This way involves conscientiousness and candor on the part of physicians. Where there's ambiguity or dispute about whether a particular practice belongs in medicine, physicians and patients have a respectful and candid discussion so that they can negotiate an accommodation that does not require either to do what they believe is unethical. In this model, physicians would not feign moral neutrality, but instead would tell their patients frankly what the options are, which ones the physician is willing to provide, and why the physician recommends one over the other. The scope of permissible accommodations will have to be set through a political process. But I would echo the conclusion reached by the President's Commission in 1982, 27 years ago, which is that considerable flexibility should be accorded to patients and professionals to define the terms of their own relationships. This model would encourage policy accommodations that provide reasonable access to controversial technologies without asking physicians to provide interventions to which they object. So it would seek policy accommodations that don't force one person's freedom to seek to obtain something to be purchased at the cost of another person having to participate in what they think is unethical. In conclusion, unless and until consensus is forged regarding the ends of medicine, refusals of controversial practices cannot be shown to violate physicians' professional obligations. In the meantime, the practice of medicine should be open, I think, to anyone who is willing to unreservedly commit herself to caring for the sick so as to preserve and restore their health. In light of deep moral disagreements in our society about the scope and limits of medicine, the profession should invite differences in practice so long as physicians are candid about their practices so that patients can effectively participate in decision-making. Conscientiousness, when accompanied by candor and respect, gives a limited ground, but a very real ground, for patients to trust physicians as they work out accommodations in the face of genuine disagreement about how to apply medical science toward the patient's good. Thank you.